Uh, I will ask the last speaker, Dr. Amir Arain.
Dr. Amir
Dr.
Arain is
Amir
a
Arain is
professor of
a professor of
epilepsy
epilepsy
medicine and
medicine
chairman
and
of
chairman of the
division of
Division of
epilepsy
Epilepsy
medicine
Medicine
at
at
University of
University of
Utah.
Utah.
Thank you for the
Thank you for
invitation.
the
Thank you for the introduction. I'm going to talk about some updates in epilepsy. It'll take about 10 minutes. This is my disclosure. Epileptogenesis is a process through which a normal brain becomes epileptic or starts developing seizures. Since most of the anti-seizure medications don't affect that process, currently the term anti-epileptic drugs have been abandoned, and now currently we talk about anti-seizure medications. Epilepsy is the second most common neurological condition after stroke. More than 3.5 million people suffer with epilepsy in US, and about more than 65 million people in the rest of the world have epilepsy. One in every 26 people will develop epilepsy, so it's quite common. Why it's important for you to know, because most of the patients who are started on seizure medications are not by neurologists. More than 70% are started on anti-seizure medicines by non-neurologists, and day-to-day treatment for seizures is provided by primary care providers, internal medicine, family practice, and ER physicians. What are the consequences of uncontrolled epilepsy? Often leads to ED visits. It results in reduction of quality of life. Injuries are sustained during seizures, and there is a higher risk of premature death. And suddenly, a sudden unexpected death in epilepsy is a grave complication of epilepsy, with the incidence of about 1 per thousand in epilepsy patients, and about 1% in refractory epilepsy patients who come to an epilepsy center. Previously, it was thought that this epilepsy is a condition of children. As you can see, there's two peaks, especially there's a sharp rise after age 60. So we are seeing more new onset epilepsy in elderly patients than pediatrics. And epilepsy in this age group typically presents because of cerebrovascular accidents, dementia, and head trauma. Just to give you an idea, like in resected brain, where we get like hippocampal sclerosis, we also see tau. So there is evidence of neuronal damage there. More than 60% of Alzheimer's patients have subclinical seizures, and it's highly recommended that you should do some video EEG monitoring in order to diagnose it. The medications that are effective in elderly are lamotrigine, levetiracetam, gabapentin, brivaracetam, and lacosamide. But the same principle is effective here, like start low and go slow in elderly population. They are very amenable to be treated with medications, but on the same token, because of the different pharmacodynamics, they are very sensitive to side effects as well. One update is that we knew that stroke can give rise to elderly epilepsy, and dementia can give rise to geriatric epilepsy. But this relationship is bidirectional. That's new data that geriatric epilepsy can lead to dementia, and similarly, geriatric epilepsy can result in cerebrovascular accidents. So if a patient presents with new onset epilepsy in an older patient, and they have not had any cerebrovascular accident, it will be mandatory to work them up for possible strokes. So since 1993, there are more than 20 medications that have come out in the market, and the recent additions, one of the recent addition is cenobamate, which is an excopri. It has dual mechanism. It's a sodium channel blocker as well as a GABA agonist, and it shows in very refractory focal epilepsy population that it gives you 20% seizure freedom. And the common side effects are dizziness, somnolence, headache, and there was an incidence of DRESS about 0.21% during the development of this medication. So it resulted in slowing down the titration. Now it follows the same titration schedule as lamotrigine. So you start at a smaller dose and increase it every 2 weeks. Um, just to give you an idea that in other seizure medications, there has not been a head-to-head comparison with other seizure medications, but in the same double-blind placebo-controlled trials, meta-analysis, typically the seizure freedom we see is about 2 to 6%. On the contrary, in the same population, very refractory epilepsy, we see 20% seizure freedom in this medication. So that's very promising. The other addition is nasal diazepam and nasal midazolam that has come out for acute seizure cluster. Both of them are effective. They have different pharmacodynamics. It's easy access without patient cooperation. The patient or caregivers can directly insert it. It comes pre-filled. You don't need to prime it and just give it in the nasal cavity, and that gets absorbed really fast, and that helps with the stopping of the seizures. So we are using it quite a bit, and that helps them from coming to the ER, because certainly ER visit is very expensive. So if you give this, patients feel empowered and the caregivers feel empowered. So this is something that should be available in Pakistan also. Another medication that has been out is fenfluramine, which was previously a diet pill. It's a novel mechanism. It works through the serotonergic pathway, and now it has been approved for Dravet syndrome, Lennox-Gastaut, and tuberous sclerosis. And it seems to be effective, very well tolerated. But there's a concern about pulmonary hypertension and valvular heart disease when it came out back in 90s as a diet pill. So it was taken off the market. Now this medicine is being used for epilepsy, refractory epilepsy, but at a very low dose compared to what it was given in 1990s. So it seems promising, and we are using it. Uh, Lastly, I wanted to talk to you about sudden death in epilepsy. It's a grave complication. We talked about that the incidence is about 1% in refractory epilepsy. Just to give an idea that if you have one generalized tonic-clonic seizure a year, the risk for SUDEP is about 10 times. And if it more than three seizure medications, if it is more than three generalized tonic-clonic seizures, the risk of SUDEP is more than 15 times. So this is a condition of young people, typically shortly after diagnosis. They may end up in SUDEP. So the main way of treating it or preventing SUDEP is to control generalized tonic-clonic seizures, have better adherence to anti-seizure medications, and epilepsy surgery. If epilepsy is refractory, then that may bring down the risk for a SUDEP. When to consult an epileptologist? If the primary care provider has been treating the patient for 3 months and they are not successful in controlling the seizure, they should refer the patient to a general neurologist. And a general neurologist, if they have failed controlling the seizure after a year, they should refer the patient to a tertiary care center. These are the general recommendations, but you'd be surprised to see that it takes about, on an average, about 20 years for a person to come to a tertiary care epilepsy center. So if we can somehow decrease this wait time, that can certainly help in the management of epilepsy. These are the different modalities that are available for surgery for epilepsy. On the left is the temporal resection, you can see. That has the highest chance of being seizure-free, 70 to 75%. Then laser ablation has come out as one of the options where you don't have to open the skull with a small burr hole. They can put in a laser ablation catheter and you can do the laser ablation. And it gives you the similar seizure freedom, about 60 to 65%. And then we have responsive neurostimulation, which is a a device which detects the seizure focus by the electrodes that is connected to, and then shocks the brain when the seizure comes on. That gives you a seizure freedom about 15 to 20%. It's not as good as laser ablation or resective surgery, but for these patients where the seizure focus is in an eloquent cortex, this may be the only option that is available. Then we have deep brain stimulation, where continuous stimulation of the thalamic nuclei, anterior thalamic nucleus or centromedian nucleus can certainly improve seizures. The seizure freedom with that is about 12%. And then lastly, the vagus nerve stimulator. seizure freedom is only 3 to 5%. As far as improvement in seizures, all these neuromodulations give you 60 to 70% seizure improvement. On what are things on the horizon? There's a new class of seizure medications. Those are called postsynaptic potassium channel openers. We are in phase 2 and phase 3 trials that seem to be very promising. Xenon is one of them, and the preliminary data shows seizure freedom for about 23-25% of these patients. So that's very exciting in these patients who are very refractory, that you can get like 23 to 25% of seizure freedom with just the medication. And all these new medications that are being tested, like potassium channel openers, they will be out in about 2 to 3 years from now on. Another exciting area is Neurona stem cell transplant trial, where GABAergic neurons are directly implanted in the hippocampus. And in the preliminary data in animal model, it showed about 67% seizure freedom, just very close to like surgery. And now this is the first trial in humans. And we just implanted our patient like 6 weeks ago, and the patient has been doing well. So that's another pivotal trial. Once it comes out, that may change the practice. So if it shows that you have sustained 70% seizure freedom, then it may change the prospects of seizure freedom with medication rather than having epilepsy surgery. Lastly, focused ultrasound has been used very effectively in essential tremors and Parkinson's disease. Now it's being tested for epilepsy. The two high intensity focused ultrasound, which is primarily causing an ablation of the brain tissue, hippocampus primarily, or low intensity focused ultrasound, where you have low intensity but it doesn't cause any ablation. It rather modulates, it improves seizure control. So there have been some trials ongoing right now. Primarily, it is approved for high intensity focused ultrasound for tremor and Parkinson's disease. So in next few years, we'll see that it will come out for epilepsy as well. So that will be non-invasive test ablation mechanism, which will prevent any opening of the skull or making burr hole. Just through focused ultrasound, you can create a lesion, and that would make them seizure free. So I'll stop here, and if you have any questions, I'll be happy to answer. Thank you.